Doctors of Reddit, what is the most unethical thing you have done or you have heard of a fellow doctor doing involving a patient? Story 1. I was 6 months into my psychiatry residency, doing a night shift in the emergency psych unit. The department was packed. We had more patients than beds and more crises than staff. It was one of those nights where everything felt like a triage game. Who's dangerous now? Who can wait? Who gets a bed? Then came Sasha, not her real name. Early 30s, brought in by police after her neighbor heard her screaming. She had slashed her arms, not too deep, but intentionally. She told us flat out, "I hear them again. They won't shut up. I want to pass away just to stop the voices." Classic schizophrenia, but also extreme distress. And we didn't know her baseline. She had been off meds for 3 weeks after getting kicked out of her group home. She was alone, paranoid, and with active thoughts of self-harm. I evaluated her for over an hour. She was delusional, clearly in psychosis, but she kept bouncing between cooperative and combative. One moment she was weeping, the next accusing me of spying on her. I filled out the papers to admit her involuntarily. Then the attending called me off. "We have no beds. Prioritize the aggressive one from earlier. Not her. She's not violent. Send her home with meds. Reassess tomorrow." I froze. She's not safe. She hasn't made a plan. We legally can't hold her. Meds and outpatient referral. That's all we can do tonight. I argued, quietly but firmly. But in the end, we discharged her with a crisis line number, a starter pack of antipsychotics, and a follow-up appointment 2 weeks later. 2 days later, we got the call. She had jumped off a highway overpass. I remember feeling like it was personally my fault, even though I technically followed orders and protocol. But rules and system pressure can never measure someone's suffering. I started having dreams where I'd see her face in the ER, staring at me and whispering, "I told you." I burned out for weeks after that. I still think about her. Before we continue, do us a quick favor, smash that like button, and subscribe to support our channel. Story 2. This happened when I was a medical student working a night shift in the emergency department. Things were hectic, as they often are in trauma care, when a young man in his 20s was brought in after crashing his car while driving under the influence. The accident was serious. He had hit an elderly couple, both of whom were rushed into emergency surgery with life-threatening injuries. Meanwhile, the young man who caused the crash was acting completely out of control. He was intoxicated, disoriented, and strangely, completely unclothed. He wandered around the trauma bay shouting, insulting the staff, and refusing to cooperate. Nurses tried to guide him back to his bed and calm him down, but he became increasingly aggressive and disruptive. He began shouting profanities at the nurses, calling them disrespectful names, and ignoring every instruction. At one point, he asked to use the restroom. Given the situation, they handed him a urinal to use at the bedside. He began urinating while continuing to yell and cause a scene. That's when my attending physician stepped in. With a calm but authoritative tone, he told the patient, "I want you on the bed right now." The patient refused. His response was aggressive and disrespectful. In an instant, my attendant knocked the urinal from his hands. Urine splashed across the room and physically moved him onto the bed. Then, without warning, he administered a dose of rocuronium, a medication used to paralyze the body in preparation for intubation. The patient's muscles went limp almost immediately, but instead of intubating him right away, my attending paused. He watched the patient's oxygen levels slowly fall, first into the 70s, then the 60s, and eventually into the 40s, before finally securing the airway and allowing him to breathe again. There was no medical justification for this. The patient wasn't in respiratory distress. He was awake, alert, and breathing on his own. He was disruptive, certainly, but not in need of intubation. What happened wasn't about protecting the patient or others. It was retaliation, punishment. Later, I learned the young man had recently broken up with his girlfriend and gone on a dangerous drinking binge. His actions had caused enormous harm, especially to that elderly couple, but seeing how he was treated in return made me deeply uncomfortable. No matter how badly someone behaves, especially in a hospital setting, medical care should never become a tool for revenge. That experience left a lasting impression on me. I witnessed a moment where the ethics of medicine were blurred by emotion, and I realized how important it is to never let judgment override professionalism. Story 3. My father has been a psychiatric nurse since the 1970s. With decades of experience behind him, he's often candid about how jaded he has become, not because of the patients, but because of the growing incompetence in the mental health system and the decisions made by those in charge. Over the years, government budget cuts have hit mental health services especially hard. In an effort to save money, institutions have increasingly turned to hiring underqualified workers, people without proper nursing credentials, training, or experience. Rather than hiring licensed psychiatric nurses who command a higher wage, these facilities often employ individuals who serve more as babysitters than medical staff. My father's patients aren't dangerous or aggressive in the classic cinematic sense. They're not individuals who need to be strapped down or sedated. Instead, they are often adults with profound developmental disabilities functioning at the cognitive level of a young child. They need careful, skilled, compassionate supervision. Unfortunately, these new hires often lack even the most basic understanding of how to handle situations when patients become upset or aggressive. Many of them simply freeze or retreat when things escalate, waiting helplessly for one of the few trained nurses on shift to intervene. Worse than the inexperience, though, is the lack of empathy some of them show. My father once told me about a patient with a deep phobia of cicadas. One day, a staff member, apparently finding it amusing, caught a cicada and deliberately chased the terrified patient around the facility grounds. It wasn't just unprofessional, it was cruel. But the worst story he ever shared with me involved an incident at a psychiatric hospital not far from a major 6-lane motorway. It was a night shift, typically the quietest hours in such facilities. Most patients are asleep, and night staff often occupy themselves with paperwork or other tasks to stay awake. On this particular night, 2 staff members brought in computer equipment. Whether they were fixing or assembling a computer, I don't know. What I do know is that they were so engrossed in what they were doing that they failed to notice when one of the patients woke up, left his room, and wandered off the premises entirely. The facility was just a short walk from a major highway. No one noticed he was missing. It wasn't until emergency services arrived and informed the staff that there had been a fatal accident on the motorway involving a pedestrian that they realized the patient was gone. He had been hit and unalived while wandering along the highway in the middle of the night, completely unsupervised, unnoticed, and abandoned. The entire tragedy was preventable. It wasn't just a lapse in vigilance, it was systemic failure, born of budget cuts, improper hiring, and lack of respect for the needs of vulnerable individuals. My father, after decades in the field, wasn't shocked, saddened, yes, outraged, deeply, but not shocked, because when you spend your life in a system that's slowly been gutted, you see the warning signs long before disaster hits. Story 4. I was working as a scribe in the ER alongside an older doctor known for being slow and often questioned about his competence. One afternoon, a 12-year-old girl came in with her father. She was adopted and had a long history of psychological issues, as well as severe antibiotic-resistant urinary tract infections and encopresis. During the exam, I noticed something was off, but what really raised alarm bells was the father's behavior. He was attentive, but not in a normal, caring way. He seemed calm, almost too calm, and was very reluctant to let us examine his daughter thoroughly. He outright refused to let us speak with her alone, which is often done with preteens and teenagers to get honest answers. Afterward, I mentioned my concerns to the doctor. He agreed the father seemed strange but didn't pursue it further. A nurse approached the doctor later and shared her suspicion that the father might be sexually abusing his daughter, pointing out that the girl's psychological issues and recurring UTIs were common signs in abused children. The doctor said, "Maybe, but we can prove it." When asked if he wanted to talk to the girl or father again, he declined. The girl and her father left that day, and I was left feeling disgusted and helpless. I asked the nurse if there was anything more we could do, but she told me it was ultimately up to the doctor. About a month later, the same girl returned with her father and younger sister. The father gave a bizarre story about a sleepover at a friend's house where both girls stayed. He claimed he had left for an errand and upon return found his daughter out of it, believing she had been drugged by the friend's father who supposedly locked the girls in his room. The story didn't add up. Testing confirmed the girl's blood was positive for benzodiazepines, medication she was never prescribed. We called the police, and an investigation began. They could find no evidence of the friend or the friend's father. The doctor confided in me that they strongly suspected the father fabricated the story to cover his own abuse. The girl was admitted to the hospital, and I never learned what happened next. What angers me most is that two of us saw the warning signs and tried to get the doctor to act, but he refused. Maybe nothing would have changed, but maybe that girl could have been saved from a month more of abuse if someone had taken action sooner. Story 5. A doctor nearly cost my wife her life due to a lack of proper assessment. She had been experiencing intense heartburn-like pain for several days. Over-the-counter antacids and prescribed proton pump inhibitors did nothing to ease her discomfort. Concerned it could be something serious, we went to the emergency room. Once there, the attending physician asked me to wait outside and didn't allow her to give a full medical history. He performed a quick ECG, which came back normal, and without asking further questions, discharged her. He handed her a spoonful of lidocaine, a prescription for more PPIs, and casually told her to follow up with her primary care doctor in a week. No labs, no imaging, nothing beyond the ECG. Within hours, her condition worsened. She was doubled over, visibly in agony. That's when I decided to take her to a different ER on the other side of town. The experience couldn't have been more different. The doctor there actually listened to her, asked for a complete history, and quickly performed a bedside ultrasound. His face changed immediately. He called for an emergency cholecystectomy on the spot. The surgery took twice as long as expected. Her gallbladder was dangerously swollen and had to be drained for an extended period before it could even be moved. The surgeon later told us that if she had waited even a few more hours, her gallbladder likely would have ruptured, a situation that carries high risk and potentially fatal consequences. What still haunts me is how easily she could have been another case of undiagnosed pain if we had trusted that first ER visit. A lack of attention and failure to listen almost cost her everything. Story 6. I'm not a doctor, but I want to share something that happened to a close friend's father, a situation that left me both shocked and heartbroken. He was diagnosed with colon cancer, which was treated, but not long after, doctors discovered that the cancer had spread to his liver. He underwent a major surgery to remove 60% of his liver, hoping this would give him a chance at recovery. Unfortunately, shortly after the operation, scans revealed cancer in his lungs. Here's the disturbing part. When he transferred his care to a different cancer center, they reviewed his records and discovered that the previous hospital had already known about the lung cancer. Not only that, but it was documented he had both colon and lung cancer at the same time for at least 3 months, and no one had told him. The original hospital had this knowledge in his file and chose not to disclose it. They proceeded with surgery on his liver without addressing the more urgent issue, cancer that had already reached his lungs. According to the second cancer center, if both conditions had been treated together from the beginning, his outcome could have been significantly better. The man is now considering a lawsuit. From my perspective, the situation is not just unethical, it's appalling. Withholding a diagnosis, especially something as serious as metastatic cancer, robs a patient of choice, preparation, and possibly even survival. It's a painful reminder of how critical transparency is in medical care. Story 7. During my psychiatry rotation in medical school, I worked with an older psychiatrist who was originally from Transylvania. From the moment I started, something about him felt off. His manner was unusual, and at times his interactions with patients seemed cold and even unsettling. One patient stood out, a woman who suffered from frequent hallucinations that left her deeply frightened. She often spoke about feeling violated and overwhelmed by terrifying experiences she couldn't control. Instead of offering support or reassurance, the psychiatrist would make disturbing jokes, hinting that he might be the source of her fears. His comments would cause her to visibly shrink back in fear and confusion, making her distress even worse. As time went on, I found it hard to reconcile his behavior with the kind of compassionate care I thought mental health patients deserved. Later, I came across an article that explained why this same psychiatrist had lost his medical license because he refused to discharge a patient until she submitted to his inappropriate demands. It was a painful realization that the fear I saw in his patient was likely tied to a very real abuse of power. This experience deeply affected me. Psychiatrists have immense responsibility and influence over their patients, who often rely on them in moments of extreme vulnerability. When that trust is violated, it can leave lasting scars. I often think about that woman and the way she seemed trapped not only by her illness but by the very person who was supposed to help her heal. Story 8. I'm not a doctor, but I work at a methadone clinic providing support services. One client was on 250 milligrams of methadone and still used heroin and benzodiazepines regularly, sometimes right in the parking lot. He overdosed once in my office and another time in the lobby. We called an ambulance for him 4 times. Despite this, we kept increasing his dose and even phased him into a less restrictive program. He consistently tested positive for multiple substances. We weren't even sure if he was taking the methadone or selling it. After the overdose in my office, I expected we'd recommend inpatient treatment. But nothing changed. No serious intervention was made. It felt unethical. While I support harm reduction, it doesn't work the same way for everyone. In his case, we were enabling more than helping. Story 9. This isn't about a patient, but it's probably the most memorable story I've heard during med school. So, there was this cardiologist at a big teaching hospital in my city who sadly ended up taking his own life last year. The story behind it was pretty messy. He had been having an affair with his best friend's wife. Yeah, and the best friend was also a cardiologist at the same hospital. When the friend found out, word spread fast, and the whole cardiology department basically turned on the guy. They started shutting him out, and the senior doctors made sure he didn't really get to work anymore, even though he was technically still employed. His reputation got trashed so badly that no other hospital wanted to hire him either. The guy ended up totally isolated and depressed. I first heard about this during rounds at a different hospital. One of the cardiologists got a phone call and went outside to take it. When he came back, he told us that the call was from the senior doctor involved, and then he called him a total jerk for pushing the poor guy so far that he did something so tragic. Nobody was really right in this mess, but it just showed me how messed up things can get among doctors. It's a tough reminder that doctors aren't perfect. They can be just as petty and hurtful as anyone else. And sometimes, that can ruin someone's life. Story 10. When I first started as an intern, I rotated through a geriatrics rotation, elderly medicine, and I didn't have a resident above me. The registrar, kind of the second-in-command for consultants attendings, was preparing for his exams to become an advanced trainee senior registrar junior consultant, and he had already failed once. So, he was freaking out and was absent from the wards most of the day, leaving me to do a lot of the work. Now, for context, geriatric patients can be really challenging. Imagine how sick your grandmother would need to be before your family decides to put her in a nursing home. It's usually 5 or more health issues that make it too hard for families to care for them at home. When the nursing home can no longer manage because they get even sicker on top of those baseline problems, they come to the hospital. I had about 25-30 of those patients. I had been a doctor for about 15 weeks. One day, I got paged to see a patient in his 70s who was having trouble breathing and chest pain. When I arrived, he looked gray and was needing a lot of oxygen. I asked for a heart monitor, and it showed he was having a heart attack. Right at that moment, 5 family members arrived, 2 of whom were hysterical. On the front of his file was a "not for emergency response team" order, meaning I couldn't call anyone but my own team to help. I called my registrar, who was in the library studying. He told me to just give the patient a blood thinner and then hung up on me. I went to chart it but realized the patient was already on 3 blood thinners at high doses, and I couldn't bring myself to give the dose my registrar suggested. I called him back. He angrily told me he couldn't talk right now and hung up again. Frustrated, I called the consultant directly. I tried to cover for the registrar and said he was busy and I couldn't reach him urgently, then asked for advice. The consultant told me to speak to the registrar because he was in a meeting and then hung up on me. In the end, I offered the patient supportive therapy while I reviewed the clinical guidelines on our hospital intranet and managed him according to those protocols. To my credit, the patient survived that day. He had a more major heart attack 8 days later and did not survive, but I will never forget that day. It was the first heart attack I had to manage, and it taught me a lot about the enormous responsibility of being a doctor at any level. It also showed me that the responsibility is ultimately yours alone because you can never rely on the hope that others in your team will have your back. Story 11. My mom doesn't ski. Like, not at all. While the rest of us, me, my dad, and my sister were out skiing, she was just walking to the lodge to grab a coffee or something. Somehow, she slipped on a patch of ice near the entrance and ended up breaking her wrist. The ski patrol came to help and took her to their nurse doctor on site. But as soon as they realized they couldn't even get her glove off without her practically screaming, they called an ambulance right away. They went through a serious effort to get in touch with my dad, kept calling until he finally picked up. Once we found out, we raced down the mountain and met her at the nurse's station, then followed the ambulance to the hospital. Now, here's where the story stops being funny. At the hospital, they took x-rays and set the break. She got a cast, some pain meds, the usual. After we got home, she started seeing a local doctor for follow-ups. He kept taking x-rays and checking things out. But at some point, either from the ER's cast job or just bad luck, the bones had separated again after the initial setting. Despite this, her local doctor kept telling her everything looked fine. She went back for months, explaining that she still couldn't use her wrist for pretty much anything, and he'd keep reassuring her it was healing. Eventually, she got really worried and decided to get a second opinion. That new doctor took one look at the x-rays and basically said, "This never healed correctly. The break hadn't set right, and the wrist had been healing crooked the entire time. To fix it, they had to re-break it." Yeah. So, after going through that painful process all over again and months more of healing and rehab, she finally got most of her wrist function back. But by then, she was so used to not using that arm that it took a long time to rebuild confidence and strengthen it. My parents tried to pursue legal action against the first doctor, but somehow conveniently all of her old x-rays and medical records were lost. So, nothing ever came of it. Story 12. My mom had a psychiatrist, and she tried to make an appointment, but he was told he wasn't around anymore, and nobody would actually explain why, until my dad saw the newspaper. He was on trial for sexually assaulting his patients. He would say that he thought they were confused about their gender, so just let me have a feel down there. His defense was that he was carrying out legitimate tests. The scary thing is, he questioned my mom about her gender. "Do you feel like a man trapped in a woman's body?" Several times, and she continued to say no. Given her fragile history, this makes me sick to think he would do this. Not to mention how often she would stay talking to him well past the allotted appointment time. In addition, she then went to a new psych, and he asked her why she thought she had been diagnosed with bipolar. Because Dr. X told me. Well, he had never written it anywhere on my mom's notes, and she had been taking a shit ton of medication when it turned out she actually had a personality disorder that only required talking therapy. Not to mention the fact that she was taking 2 drugs that shouldn't be prescribed together for about 10 years. Story 13. I worked at a hospital for about 3 years as a transporter. Not a medical role, just moving patients from one department to another. One day, I was sent to pick up an elderly woman from the X-ray department. When I got into the room, she was lying on the stretcher, completely still. And I mean cold enough that something felt really wrong. I looked at the tech and said, "Shouldn't we call a code or something?" But she just shook her head and said she didn't want the code team rushing in and making a mess. I didn't know what to say. I was young, had no medical training, and was just doing what I was told, so I wheeled the patient back up to her room. She passed away about an hour later. It's strange to think about it now. At the time, I didn't understand the weight of what was happening. I just followed instructions. But it stuck with me. Life's funny sometimes. What you walk into thinking, it's just. Story 14. I live in Fiji and I'm currently in my 2nd year of medical school. But even before I decided to become a doctor, I had a moment that shook me deeply and honestly played a part in why I chose this path. About 4 years ago, my dad was admitted to a hospital. I went to visit him after school like I usually did. He was in a shared ward, and I remember sitting by his bedside when we suddenly heard a man in the next cubicle shouting for help. He was coughing violently, gasping, and kept yelling, "Nurse, nurse," over and over. His voice was full of desperation and fear. My dad quietly told me that the man had heart issues and had been in rough shape for days. I got up and ran into the hallway to find a nurse or doctor. The place was completely deserted. No nurses, no assistants, no doctors, no one. I panicked and ran up the stairs to the next floor because the elevator was out of order. I finally found a doctor and rushed him back down. By the time we got back, the man was foaming at the mouth. Within minutes, he was gone. Just like that. The doctor was furious. He kept repeating that the man could have been saved with a simple procedure if anyone had just been doing their job. He blamed the nurses, saying they were off somewhere on another floor, messing around, and had abandoned their post. The patient's family sued the hospital. I never found out what happened with that case, but I sincerely hope they won. That experience never left me. Watching someone cry out for help, knowing it could have been prevented, it changed the way I see healthcare. It showed me that being in medicine is more than just knowledge or titles. It's about showing up. It's about responsibility. And it's about remembering that every minute, every decision could mean the difference between life and death. Story 15. A few years ago, I worked at a hospital in the northeast of England for a short period. There was an outpatient clinic there that specialized in using Botox to treat hyperhidrosis, basically, excessive underarm sweating. The procedure involved injecting Botox into the armpits to paralyze the sweat glands, and typically there were small amounts left over in the vials after each treatment. One of the doctors in that clinic was in a relationship with one of the nurses. It wasn't exactly a secret, but it wasn't openly talked about either. What crossed the line, though, was that she started using the leftover Botox to smooth out wrinkles on her own forehead right there in the clinic. Word got around among staff pretty quickly. Some thought it was harmless since the leftover Botox would be discarded anyway. Others saw it for what it was, unapproved, off-the-record cosmetic treatment using NHS supplies, regardless of whether they were leftovers or not. Eventually someone reported it. Then, somehow, the press got hold of the story and ran wild with it. Of course, they didn't mention that it was just the dregs of the vials that were going to be thrown out. They made it sound like she was stealing medical supplies for her own personal glam sessions. In the end, both the doctor and the nurse were dismissed. Technically, they had broken protocol. Ethically, it was a gray area. But professionally, it was a serious lapse in judgment. It was one of those situations that reminded everyone in the hospital that sometimes it's not the big dramatic mistakes that ruin careers, it's the little ones, the quiet choices made behind closed doors, that eventually come to light. Story 16. I've been a family physician for nearly 10 years, and I've always tried to practice by the book. But there's one moment in my career that still weighs on me, a decision I made that wasn't technically illegal but definitely not ethical. A few years ago, I had a patient, we'll call him Jake. Early 30s, polite. Always showed up on time. He had chronic back pain from an old construction injury and was struggling to hold down jobs. I had been managing his pain conservatively, physical therapy, NSAIDs, stretching regimens, but he kept asking me for something stronger. I resisted for months, but during one particularly rough visit, he looked like he hadn't slept in days. He said he was about to lose his new job because the pain was making him limp visibly on site. He begged. He even cried a little. I caved. I wrote him a very small script for codeine with the promise that it would be temporary and he'd stay in physical therapy. At the time, I thought I was helping. I thought I was being human, but within 6 months, I learned he had been doctor shopping, getting multiple prescriptions from different clinics. My script had started the chain. I was the first one to write it. When it came to light, our practice's medical director confronted me. There was no formal investigation, hadn't broken laws, but I was deeply ashamed. I saw firsthand how easy it is to slip down that slope between compassion and poor judgment. I still think about Jake. I don't know where he ended up. I only know that he was failed by more than one system, including mine. Since then, I've been stricter. I'm still compassionate but clearer in my boundaries. I learned that sometimes the best care isn't giving someone what they want but protecting them even from themselves. Story 17. I'm a general surgery resident. We had a patient who had been on our service for about a year. An older gentleman, very ill. Occasionally he would go into respiratory distress and require intubation or BiPAP for a while, but he always bounced back to his baseline of being 8/10 sick. Everyone called him the Rock, but not in a cool, "Do you smell what the Rock is cooking?" More like a boring sick person who just sat there. He had always been a full code, meaning that in the event of dying, we would do everything we could to keep him alive. After a long time of being impatient, my attending grew tired of him and changed his status to DNR SLI, do not resuscitate intubate, which means let him pass if he starts to struggle. He didn't want this, but they justified it by claiming he lacked capacity. He was fairly lucid, but I can see that argument. So, discussions with the family began, and they specifically stated that they wanted him to remain full code. My attending disagreed and decided to call them to confirm. However, we suspect he intentionally called the wrong number multiple times and eventually made the decision himself to designate the patient as DNR SLI. 2 days later, the patient went into respiratory distress and died. I came to rounds the next morning to find 2 attendings yelling and screaming about the right thing to do. Maybe I feel that it's better that he passed as well, but his and his family's wishes were ignored and purposefully evaded. I could never go against someone's wishes. Story 18. I was working as a junior psychiatrist on an acute inpatient unit. One of my patients was Mark, a man in his late 40s with severe bipolar disorder. When I first met him, he was manic pacing the ward, talking rapidly, grandiose ideas spilling out non-stop. But beneath the manic energy was a man terrified of losing control. Mark refused medication. He said, "The meds turn me into a zombie. I don't want to be like that." He insisted he was fine and wanted to leave the hospital. Because of his condition and the risk of harm to himself or others, we kept him on the unit under involuntary hold. Every day was a battle coaxing him to take his meds, explaining why he couldn't leave, and trying to build trust. One night, Mark disappeared from the ward. Staff found him wandering outside on the hospital grounds, confused and disoriented. We brought him back in, and this time, he was furious. He yelled, "You that are imprisoning me. You don't care about me, just controlling me." I understood his anger, but I also knew that if he left untreated, his mania could spiral into psychosis, putting him at serious risk. We tried a new approach, more listening, less coercion. I spent hours talking with him, learning about what scared him most. Slowly, he agreed to try a lower dose of medication and some group therapy. Over weeks, Mark stabilized. He started to laugh again, to plan small things for the future. When he was discharged, he thanked me quietly. But I couldn't shake the guilt. How much of his recovery was real, and how much was just survival within a system that controlled him? Psychiatry isn't just medicining, it's constant negotiation between care and control, trust and power. And sometimes, you wonder who's really free. Story 19. During my psych rotation as a medical student, I met Alia, a 19-year-old girl who had been in and out of the emergency department for months. Her file was thick pages full of phrases like attention-seeking, manipulative, and frequent flyer. The nurses rolled their eyes whenever her name came up. Alia had a history of self-harm, panic attacks, and what the team called emotional dysregulation. She would show up sobbing, saying she couldn't take the pain anymore, that she wanted to die. She'd be admitted for a night or two, and then discharged with a referral to outpatient care she never attended. But here's what struck me. Every time I sat down to speak with her, really listen without the filter of the notes, I saw something else. She wasn't manipulative. She was terrified of being abandoned, of being dismissed, of being seen as crazy. One night she came in again, shaking, crying, with fresh wounds on her arms. The on-call psych consultant sighed and said, "Give her a sedative. She'll be fine by morning." But something felt off. Her eyes were different this time, hollow. I stayed a little longer after my shift ended. Talked to her. She kept whispering, "I don't think I still survive the next one. I really don't." I pushed for a proper inpatient psych admission. It wasn't easy, the consultant resisted, citing limited beds for real cases. But eventually, I convinced a senior registrar to review her. Turns out, Alia had undiagnosed borderline personality disorder and complex PTSD from years of abuse at home. Her drama was trauma playing out loud because nobody had ever really seen her. She stayed in the hospital for 2 months. With the right therapy and support, she made huge progress. On my last day of that rotation, she gave me a crumpled note that said, "Thank you for treating me like a person. You saw me before I saw myself." Story 20. I was a second-year resident working in internal medicine. One day, a 28-year-old woman, Jess, came into the ER with chest pain, dizziness, and shortness of breath. She was pale and visibly shaken. Her vitals were mostly normal. The ECG was clean and troponins were negative. The attending looked at her, looked at the labs, and said, "Classic panic attack. Psychiatry can take it from here." It wasn't the first time she had shown up either. Her chart had a few similar visits in the past year, always with vague symptoms that didn't match the labs. The previous notes painted a picture: likely somatization, anxious young female, reassure, discharge. She cried when we told her it was likely anxiety again, begged us to run more tests. Something about her made me pause. She kept clutching her stomach and saying, "It burns, it's like fire under my ribs." Not something I'd usually associate with a panic attack. So, I asked to keep her overnight for observation, not because I thought she was physically unwell, but because I didn't want her to feel dismissed again. Just a gut feeling. I requested a CT abdomen the next morning. The radiologist called us directly after reading it. Jess had a ruptured splenic artery aneurysm. She was bleeding internally the entire time. She was rushed into emergency surgery and barely survived. A few hours later, the same attendant who brushed her off came to the ICU and stood quietly at the foot of her bed, reading her chart. I've never forgotten that day. We almost sent her home to die because she looked like just another anxious girl. Story 21. During my psychiatry residency, I worked in a rural mental health outreach program. We were called to assess a 19-year-old woman named Asha who lived in a remote village. Her family said she had been possessed by spirits for the past year. She would mutter to herself, sometimes scream for no reason, and hadn't bathed or changed clothes in months. They had taken her to multiple shamans and temples. Each time they were told different spirits were inhabiting her. They'd done rituals, burnt herbs, and even kept her locked in a room during purifications. Nothing worked. She had stopped eating properly and would occasionally slap herself or laugh uncontrollably. When we arrived, I'll never forget the smell of the room. It was dark, unclean, and filled with incense. Asha was curled in the corner, rocking slightly and whispering to herself. Her eyes darted around the room, but when I gently spoke to her, she looked at me for a long moment and said clearly, "They're watching me. You brought more of them." It was classic untreated paranoid schizophrenia, and she'd likely been suffering for over a year with zero medical help. We had to work for weeks with her family to slowly explain that this wasn't a curse or punishment. It was a treatable mental illness. It took medication, therapy, and a lot of unlearning cultural stigma. But 6 months later I saw Asha walking outside with her mother, smiling faintly. She was still healing, but she was present again. Story 22. I was a junior doctor in surgery rotation when a case came into the ER, a middle-aged man involved in a motorbike accident. He had internal bleeding, and imaging showed his spleen had ruptured. The attending surgeon, known for his confidence, some would say arrogance, took him into the OR for an emergency splenectomy. The operation seemed to go fine, no complications. Everything went smoothly. But the next day, the patient's vitals crashed. We were all scrambling to figure out what was wrong. More scans, blood work, then came the bombshell. The spleen was still inside him. The surgeon had removed a perfectly healthy portion of the pancreas. Total human error. Somehow the bleeding source had been misidentified, and during the chaos and rush of the emergency, the surgeon made a critical mistake. To cover it up, he claimed the patient had a rare anatomical variation, but the internal documentation which I saw with my own eyes showed otherwise. The patient ended up needing another surgery to actually remove the ruptured spleen. He survived, thankfully, but had a longer and more painful recovery than necessary. What shocked me more was that the surgeon was never disciplined. The hospital quietly moved him to a less critical unit, and the family was never told the full story, just complications during surgery. I was too junior to do anything at the time, and I still think about that case. We swore to do no harm, but sometimes the harm is buried under silence and ego. Story 23. During my third year of medical school, I was doing my general surgery clerkship. Honestly, I didn't like most of the surgeons in that department. They were egotistical and unprofessional, and only seemed to value students who sucked up to them. It went far beyond the typical surgeon stereotype. I had shadowed surgeons before and always wanted to become one, but this department was a mess. One night, during a routine call shift, the attending informed me about a unique case, a woman in her early 70s, brought in by ambulance after she complained of dizziness at her GP's office. On the way to the hospital, that ambulance got into an accident and flipped. A second ambulance brought her in, now also needing evaluation for possible internal injuries. Her CT scan was reviewed and reported as normal, no signs of bleeding. She was alert, chatting, and seemed okay. I checked on her periodically throughout the evening. At around 11 p.m., the attendant said I could go home since things had slowed down. I said goodnight to her, let's call her Mrs. X, and left. The next morning at 5:30 a.m., when I got to the morning meeting, the atmosphere was tense. The department head entered, sat silently, then erupted into one of the angriest tirades I've ever seen. Apparently, sometime around 1-2 a.m., Mrs. X began losing consciousness and was rushed to the ICU. She was now in a coma with little chance of recovery. The CT had actually shown a lacerated spleen, something both the radiologist and the surgical team missed. Even worse, the resident on call had written a vague order for 24-hour observation without specifying any parameters. Because of that, no one was monitoring her vital signs properly. Everyone just assumed someone else was on it. The department head tore into everyone, the resident, the attending, even the nurses. It was brutal. He ended the meeting by asking, "What are you going to tell her family?" Months later, during my family medicine rotation, I met an elderly man, Mr. X. He came in for a minor issue but mentioned that his wife had died a few months ago. She had been sent to the hospital after feeling dizzy, and he told me about the ambulance accident. He said the doctors told him they had done everything they could, but he had been in the ER with her that night, and said he couldn't get anyone's attention for hours, even though she seemed to be getting worse. That day changed how I viewed responsibility in medicine. It wasn't just about misdiagnoses, it was about communication, systems, and real human lives. Story 24. During my internal medicine rotation, I was shadowing a senior physician during morning rounds. One of our patients was an elderly man in his late 80s. He was admitted for pneumonia but seemed stable, cheerful, even, and often joked with the nurses. That morning, we entered his room like usual, but something was off. He was sitting in the chair, clutching a folded piece of paper in his trembling hands. No machines were beeping, and no TV was on. He looked at us, eyes red, and quietly said, "I think ICEP had enough." The attendant asked gently, "Enough of what?" He handed over the paper. It was a DNR, do not resuscitate form. He said, signed overnight. My wife died here last year. No one told me she was that close to the end. I don't want to leave like that, full of tubes, no dignity. I said, "Not afraid of dying. I said, "I'm afraid of not being heard." We all stood in silence. The room, which had been just another patient's chart an hour ago, now held the weight of his entire life story. Later, I sat alone in the resident lounge, thinking about what he said. We learned so much about how to fix the body, but so little about how to listen to the soul in front of us. That day, I realized being a good doctor isn't just about saving lives. It's about knowing when not to. Story 25. It was the second month of my pediatric rotation. I had expected long hours, crying infants, and exhausted parents. What I hadn't expected was Sammy. Sammy was 8 years old and had been in and out of the hospital his entire life. He had cystic fibrosis. And by now, everyone knew him. He'd glide down the hallways in his wheelchair, with colored pencils stuffed into the armrest pouch. If you were lucky, he'd draw you. If you were special, he'd give it to you. The first time I met him, he looked up from his sketchpad and said, "Are you new?" I nodded. "Okay. Don't try too hard. Most grown-ups do, and then they cry when I get worse." He said it with a smirk and a weird kind of peace, like he had memorized the script of his own life. Over the weeks, I found myself visiting him, even when I wasn't assigned to his floor. He would tell stories about colors, how red could scream or whisper depending on the shade. He said lungs were blue sometimes, not because they were sick, but because they were tired of fighting. His condition worsened in early February. The team discussed transferring him to ICU, but he had a DNR in place, signed by his mother, who was, by then, worn down by grief but strong in conviction. "He told me he wants to go watching the sky," she said. "No tubes, no masks, just the sky." That evening, I found him at the window, sketching what he could see, streaks of orange melting into purple. "Almost done," he whispered. "Just need the stars." I asked if I could sit with him for a while. He nodded. I sat beside him for an hour, saying nothing. I just watched his hand move slowly over the paper. Around midnight, a nurse found him slumped over, pencil still in hand. He passed quietly, peacefully, in the exact way he had asked to. The next day, his mother gave me the final drawing. The sky was perfect, but in the bottom right corner, he had written, "Don't be sad. I got my stars." I still keep that drawing. Sammy taught me something that no textbook ever could. Some people are here to live long. Others are here to live fully, even if for a moment. And sometimes the kindest medicine is simply letting go, with love, dignity, and a sky full of color. Story 26. It was a Friday night in the ER, the kind of night where time blurred, coffee went cold, and traumas came in back to back. I was a fourth-year med student, exhausted but chasing adrenaline, assigned to triage with Dr. Kamal, a sharp trauma attending who rarely said more than necessary. At around 11:45 p.m., a call came in, incoming female, late teens, found unconscious in an alleyway, possible overdose, signs of physical trauma, ETA 5 minutes. When she arrived, she looked like a doll someone had given up on, skin pale, wrists bruised, makeup smeared like she'd cried herself out hours ago. But what caught my attention wasn't her injuries. It was the small tattoo on her shoulder, a butterfly, vivid blue, fresh. We worked fast. Narcan, fluids, oxygen. She started to stabilize. She woke up with a gasp, eyes wide like she'd been yanked from a nightmare. She panicked when she saw the IV in her arm and tried to pull it out. "I don't want to go back," she screamed. The charge nurse held her gently. "You set her safe now, sweetheart." We learned her name was Maya, 17. A runaway. She wouldn't say much, but every time she looked at the butterfly on her shoulder, she seemed calmer, like it grounded her. I stayed late that night, reviewing charts. Around 3 a.m., Dr. Kamal tapped me on the shoulder. "Come with me." He led me to a hallway near the psych wing. Maya was sitting there, head in her hands. A woman in scrubs stood beside her, short, tense, and nervous. "She's a caseworker," Dr. Kamal whispered. "Maya's been in and out of group homes. She ran away from the last one after reporting abuse. No one believed her." I nodded, heart sinking. "She's refusing to go back. She says she's still off herself if they make her." Then he looked at me. "What would you do?" I didn't know what to say. I wasn't a psychiatrist. I wasn't a legal expert. I was just a student. But something felt off. "Can we stall discharge?" I asked. Kamal raised an eyebrow. "Already did. Bought her 24 hours. I sat with Maya for a while after. She told me, in pieces, about the home, about a staff member who watched the girls shower and who gave medicine that made her dizzy and numb, about the tattoo, done by another runaway she met briefly. "It's a promise," she whispered, "to myself, that I'd fly away, no matter what." The next morning, a social worker who actually listened got involved. They opened a formal investigation. Maya wasn't sent back. she was moved to a temporary foster placement, not perfect, but safe for now. Before she left, she handed me a napkin with a small sketch of a butterfly on it, for you. So, you remember, not all broken things want to be fixed. Some just want to fly. Story 27. During my third year as a medical student, I was assigned to a night shift in an old hospital wing, known for its eerie atmosphere. One evening, I was called to check on a patient in room 317, an elderly woman admitted for severe pneumonia. She was disoriented, whispering about shadows moving just beyond the corners of her room. She kept insisting, "They watch me through the vents," and warned me to never stay after midnight. Curious but uneasy, I left the room and went to grab some supplies. As the clock neared midnight, the hospital corridors grew unnervingly silent. No monitors beeped, no footsteps echoed, just an oppressive stillness. I returned to room 317 to find the woman staring blankly at the ceiling, her eyes wide but unblinking. Suddenly, the overhead lights flickered and dimmed. I heard faint scratching noises coming from the air vents. Then, in a voice not her own, she whispered, "They're coming." The room temperature dropped sharply. I wanted to call for help, but my phone had no signal. Shaken, I left the room to find the hallways strangely empty. The night staff had vanished. On my way back to the nurse's station, I caught a glimpse of something moving just at the edge of my vision, a shadow slipping into a nearby room which was supposed to be empty. When I entered that room, it was freezing cold and the walls were covered in old faded hospital records with dates going back over 100 years. Suddenly, a chilling voice echoed through the hallway. "You shouldn't be here." I ran to the exit, but the doors wouldn't budge. The lights flickered one last time before going out completely, plunging me into darkness. Moments later, the emergency power kicked in, and I was alone again, or so I thought. To this day, I avoid that wing at night, and sometimes when I pass by room 317 during the day, I swear I can hear whispering from the vents. Story 28. During my psychiatry rotation, I was assigned to a quiet rural hospital known for taking long-term mental health cases. Most of the patients had chronic conditions, but there was one woman, patient 46B, who unsettled everyone. Her file was thin, no family contacts, no past records, just her arrival from a police station where she had been found wandering in the woods, barefoot and muttering. She never spoke to anyone, except once every night, at exactly 3:03 a.m. The night nurses said she'd sit upright and whisper the same phrase, "Don't let it in." They thought it was some form of trauma loop, maybe related to PTSD. The weird thing was, her room was always colder than the rest of the ward, not slightly, but cold enough to see your breath, even in summer. One night, I stayed late catching up on notes and, out of curiosity, passed by her room at 3:03 a.m. I stood outside her door. The hallway lights flickered, just once. Then I heard her voice through the door, clear, calm, not whispered this time. She said, "You shouldn't be here." I opened the door. She was sitting up in bed, staring straight at me with pitch-black eyes. Not metaphorically dark. Her irises were completely black. I froze. She smiled faintly and said, "You let it in." The power cut out instantly. The hallway went pitch black. I heard a dragging sound, heavy, wet, slow-moving toward me from the end of the corridor. I slammed her door shut and ran to the nurse's station, heart pounding. When the emergency lights kicked in, the hallway was empty again. The next day, her room was locked and marked as under maintenance. When I asked, the staff just exchanged glances and shrugged. Her file had disappeared from the system. It was like she had never been admitted at all. To this day, I still dream of her black eyes and that dragging sound and always wake up at exactly 3:03 a.m. Story 30. I was a junior lab technician at a large, well-known private hospital. It was my first job out of university, and I was eager to learn, maybe too eager. I didn't realize how deep things ran until I accidentally uncovered something that changed my view of the healthcare system forever. It began with a blood test. Routine, supposedly. A young woman had come in complaining of fatigue and shortness of breath. The GP ordered a full panel. I ran the tests like usual, but her white blood cell count was dangerously high, like leukemia level high. But when I opened her file the next day, the result had been changed. It showed everything as within normal range. Confused, I reran the test. Same critical result. This time, I printed a hard copy and quietly went to my supervisor. She looked me straight in the eye and said, "We don't question senior consultants here. File your work and move on." I couldn't let it go. Over the next few weeks, I noticed this happening more often: altered lab results, suspicious signatures, and patients being discharged too early. Then I found out the hospital was under pressure from a private insurance group that funded most of its operations. Patients who were considered unprofitable were being marked healthy and discharged, while others were over-tested and overcharged for conditions they didn't even have. One night, I made the mistake of confronting one of the administrators. I didn't accuse him, just hinted that I had concerns. The next morning, I was locked out of my workstation. My supervisor claimed I'd violated patient confidentiality. I was suspended. A few days later, a nurse I'd befriended called me in tears. The young woman whose blood test I flagged had collapsed at home. Diagnosed too late, acute leukemia. She died 2 weeks later. I decided to go public. I sent everything I had, printouts, altered reports, audio recordings, to a journalist. The story broke within a week, and the hospital's name was everywhere. But in the chaos that followed, a lot of staff resigned or were fired quietly. The main consultants, still practicing. The hospital rebranded a year later. I never worked in a hospital again, but sometimes, I still wonder how many people died quietly, never knowing they were just numbers on a balance sheet. Story 31. During my internal medicine rotation, things were usually predictable: rounds, charts, vitals, and the occasional confusing symptom. But one week, a very minor mystery took over the break room. It started when someone's lunch went missing. It was a tuna sandwich, carefully labeled with a sticky note. "Do not touch, Dr. Amir." Naturally, everyone assumed someone had made a mistake. But then, the next day, another lunch disappeared, this time: chicken salad. Soon, almost everyone began labeling their food aggressively, using warnings like "lab sample, do not eat," or "contains laxatives." Still, the food kept vanishing. One of the nurses even set up a decoy lunch: an old sandwich stuffed with cotton balls and chili sauce, gone within hours. Eventually, one of the residents jokingly installed a cheap motion-activated camera near the fridge. The footage? It revealed the culprit, an elderly patient from the geriatric ward who wandered at night and thought the break room fridge was his own kitchen. He'd been sleepwalking down from his room and taking random sandwiches, usually picking the ones with the politest warnings. When we gently confronted him, he laughed and said, "I thought the staff were just generous." We made sure he had better snacks in his room after that, and the break room lunch thief saga quietly ended. It wasn't dramatic, but for a few days, it gave the whole department something silly to bond over. Story 32. During a busy shift in the ER, a young intern was helping triage patients. A middle-aged man walked in looking worried and said, completely serious, "I think I sit pregnant." Naturally, the intern tried to keep a straight face. She gently asked, "What makes you think that, sir?" He said, "My stomach's been growing. I feel movement. I get cravings. My wife even joked about me nesting." He was a large man with a very round belly and was clearly anxious. The staff assumed it was probably just bloating or gas, but they played along with compassion. The intern ordered an abdominal ultrasound, mostly to ease his nerves. The radiologist did the scan and started laughing. Then the attendant laughed. Everyone braced for the results. Diagnosis? The man had a massive amount of constipation, like biblical-level poop buildup. The ultrasound image was passed around the ER for weeks, titled "Baby Ruth." The man was given laxatives, had a great bowel movement, and came back the next week with flowers for the intern saying, "Thanks for delivering my food, baby." Story 33. During my pediatrics rotation, I spent one slow afternoon helping a 5-year-old boy who was very upset because he lost his dinosaur sticker. He had just gotten his flu shot and was rewarded with a sparkly green dinosaur sticker. 10 minutes later, a full-blown meltdown. "My dino is gone." So I spent the next 20 minutes helping him retrace his steps like we were solving a crime scene. We looked under the chair, in the hallway, and even in the sharp spin. Don't worry. I stopped him before he got too close. Finally, his mom looked at the back of his hoodie and said, "It's right here." It was stuck to him the whole time. He cheered, gave me a high five, and told me I was the best dino detective ever. I didn't document it in his chart, but it was the highlight of my day. Thank you for watching. If you enjoyed this video, be sure to give it a thumbs up, subscribe, and hit the bell icon so you never miss an update.